All right, well, welcome everyone. Thank you for coming to today's seminar, which is also Alem's dissertation proposal hearing. His committee is here, and we're going to have the whole group attend his presentation, and then afterwards the committee is going to meet with Alem separately. His dissertation proposal is the use and comparative safety of roflumilast in patients with COPD. So without further ado, Alem, take it away.
Thank you, Dr. Kadeb, for the introduction. Good afternoon, everyone, and thank you for coming. Dean Schumacher is in the room. As Dr. Kadeb stated, my presentation title for the planned dissertation work is the use and comparative safety of roflumilast in patients with chronic obstructive pulmonary disease. Before going to my presentation, I would like to thank my dissertation committee. Dr. Greg Kadeb is my academic advisor and the chair of the committee. I have Dr. Todd Lee, Dr. Lisa Sharp, Dr. Min Ju, and Dr. Lori Wilkin on my committee. The outline of the presentation will include a background section regarding the symptom and diagnosis, as well as management of the disease condition. I will also give a brief description about the medication of interest, which is roflumilast, about its efficacy and safety, and then I will go into the proposed studies specifically, study 1 to 4, and finally list out some of the limitations associated with the proposed study. Starting with a little bit of background. As you may already are aware of, COPD is a disease characterized by persistent respiratory symptoms and airflow limitation due to airway and or alveolar abnormalities. The majority of patients with COPD are either current or former smokers, but also other environmental as well as genetic risk factors can lead to the disease condition. And these risk factors leads to the initiation of inflammatory process, which ultimately leads to the development of COPD, which is characterized by irreversible airflow limitation. This airflow limitation is associated with either excess mucus secretion, as well as destruction to the lung structure, which leads to collapse of the airways, which makes breathing difficult for patients with COPD. In terms of epidemiology, this is a map from the BERPS 2014 data that shows the prevalence of the disease in the United States for individuals who are 18 years and above. And based on this study, the prevalence of the condition ranges from 3 to 12%, based on which state you look into. In another more specific study that looked at working adults in the United States who are aged 40 to 70 years, the prevalence estimate was around 4%, and the majority of individuals who are affected by the disease condition are females, those with white race, an age group of 55 to 70, as well as current smokers. According to the National Center for the Health Statistics, the disease burden of COPD is estimated in terms of both office-based physician visits, emergency room visits, as well as number of mortality. Accordingly, COPD accounted for 3.2% of office-based physician visits, in which COPD was indicated on the medical records. The number of visits to the emergency room was estimated to be more than 7 million. In terms of mortality, COPD is classified as the fourth leading cause of death in the U.S. in 2016, accounting for more than 135,000 deaths. Coming to the diagnosis and symptom of the condition, the diagnosis of COPD is based on the presence of symptoms as well as associated risk factors. It's recommended that any patient presenting with these symptoms that are shortness of breath, chronic cough, and sputum production, with or without the history of exposure to the disease risk factor, should be considered for the diagnosis of COPD. And the identification of the disease is not solely based on the signs, but having multiple of these factors increase the likelihood of COPD diagnosis in addition to spirometry measure. The management of COPD focuses on improving or reducing symptoms, improving the health status of patients, increasing exercise tolerance, reducing disease exacerbation as well as mortality. And the management strategy includes both pharmacological and non-pharmacological methods. But in addition to these measures, patient education to induce behavioral change, especially smoking cessation, as well as comorbidity management is important. So it's kind of a very wide or broad approach to the disease management process. When we look at pharmacotherapy, this diagram depicts some of the currently available treatments for COPD. Most of the medications available for treating this condition are uses inhalational devices, and they are classified according to their duration of action. As you can see from the diagram, we have short-acting bronchodilators, we have long-acting bronchodilator, as well as combination inhalers, including triple combination therapies. In addition to that, we also have orally administered medications, which includes roflumilast, which is a PDE4 inhibitor, as well as oral corticosteroids. The natural course of the disease is progressive, therefore, and there are currently no evidence of any medication that stops this disease progression. So the choice of treatment depends on the level of symptom the patient is experiencing, the airflow limitation and the extent of exacerbations, patient's physical functioning and preference, as well as other factors such as accessibility, cost, as well as side effect profile. The management strategy when it comes to initial pharmacological therapy in COPD patients is most of the time based on the GOLD grouping, which GOLD stands for the Global Initiative for Chronic Obstructive Lung Disease. And when we pick a particular treatment after the initial diagnosis of the condition, we'll be grouping patients into either of these four groups, depending on their level of symptom as well as the number of exacerbations. For example, we can take group A, which corresponds to having a lower level of symptom and a very small number of exacerbations, 0 to 1 moderate exacerbation. So if a patient is assigned to that group and a bronchodilator is recommended, whereas on the other hand, if a patient is assigned to group D, for example, which corresponds to having a very high level of symptom, as well as frequent exacerbations, combination therapies are recommended as an initial treatment. Following the implementation of this initial therapy, patients should be assessed for attainment of the treatment goal frequently, and any barriers for successful treatment needs to be addressed. But after the review of the patient response to treatment initiation, adjustment to pharmacological treatment may be needed, and this is based on the management strategy for follow-up treatment. And this strategy is again based on the level of symptoms and exacerbations, but the recommendations do not depend on those GOLD grouping that I described earlier. These follow-up recommendations are designed to facilitate management of patients taking maintenance treatment, whether it's early after initial treatment or after years of follow-up. So in this case, we'll be considering the predominant treatable target, which is, as you can see from the top of the diagram, we have either shortness of breath or exacerbation. So based on that, we will assign a patient into a corresponding box depending on their current treatment, and we will follow the arrow to either change their medication, increase the dose, or switch the medications completely. Among the pharmacotherapy that's available for the treatment of COPD, roflumilast is one of the orally administered medication, It's a selective inhibitor of the phosphodiesterase 4, and it has been shown to reduce exacerbations and improve lung function in patients with severe or very severe COPD. The medication was approved in March 2011, and in patients with COPD exacerbation, the level of inflammatory mediators is very high, and the suppression of these mediators helps reduce symptoms and as well as associated exacerbation. Roflumilast is able to achieve these benefits by its ability to prevent the hydrolysis of cyclic AMPs. The increased level of cyclic AMPs in these inflammatory cells leads to a decline in the release of inflammatory mediators and cytokines. So through that mechanism, the medication is able to reduce symptom and prevent exacerbation in patients with COPD. In terms of efficacy, several prospective randomized clinical trials have shown that roflumilast has the ability to improve lung function, which is measured in terms of pre-bronchodilator and post-bronchodilator forced expiratory volume in 1 second measurements. And in those measurements, the medication has shown up to 88 milliliter and 97 milliliter of improvement respectively. Whereas in terms of its effect on exacerbations, there was a significant reduction in the number of exacerbations, and that reduction can reach up to 30%, which is a very significant amount. In terms of quality of life measurements, all the studies have shown there is a slight improvement in quality of life measures, but most of the results were not statistically significant. In terms of safety, which is still the major concern with using this medication, patients who are taking roflumilast experienced more side effects, and this led to more withdrawals from the clinical trials which were conducted to test the safety and efficacy of this medication. The most commonly reported side effects were GI-related side effects, weight loss, as well as psychiatric-related adverse events, in addition to other serious cardiac and respiratory side effects. Next, I'll jump into the safety outcomes of interest for this dissertation work. In this section, I will be reviewing those outcomes that are related to the GI system, the respiratory system, as well as those related to psychiatric-related adverse events. Starting with the GI-related adverse events, the most commonly reported GI-related adverse event is diarrhea. Several things can cause diarrhea, including medications that an individual is taking at any point in time. For roflumilast, this side effect has been reported by patients who are taking the medication, and its a risk of having this side effect has been shown to be significantly higher in the roflumilast group, and most of the effect estimates that you see here are using data that was pulled from the clinical trials. The exact biological mechanism that leads to diarrhea in patients taking roflumilast is not yet clear, but two mechanisms have been proposed. One is an increased level of glucagon-like peptide 1, and an increased level of that glucagon-like peptide 1 leads to increased colonic movement, which leads to the observed side effects. In addition to that, an increased secretion of bile acids has been also proposed. An increased level of bile acid leads to electrolyte and water retention in the colon, which again leads to an increased colonic movement, which is observed through experiencing diarrhea. The next safety outcome of interest I will be looking into is related to psychiatric-related, and I will be looking at anxiety and/or depression. In patients who are taking roflumilast in the clinical trials, a higher incidence of psychiatric-related adverse events was reported. A recent meta-analysis puts the odds ratio of experiencing psychiatric-related adverse events more than twofold. But for anxiety and depression, the odds ratio are 1.81 and 1.59 respectively, which is a significantly higher number. Given these findings from the clinical trial, the FDA actually released a warning regarding the possible psychiatric-related adverse events. In the medication guide for roflumilast released by FDA in 2013, they included a statement that reads as, patients taking roflumilast may develop mood or behavior problems, including new or worse anxiety and or depression. The clear biological mechanism underlying this adverse outcome is not, again, well established, but it is thought to be mediated through the effect of the medication on PDA4 inhibitors or PDA4 receptors found in the brain. The last safety outcome I'll be focusing on in this work is related to the respiratory system, particularly pneumonia. Pneumonia was reported as a serious side effect in studies evaluating the efficacy as well as safety of roflumilast. And based on those findings, the incidence was relatively similar between the groups. But one study, the REACT trial in 2015, found out that actually patients who on roflumilast experienced a lower risk of pneumonia compared to placebo. What makes this point very important is that COPD is commonly reported comorbidity in studies evaluating the risk of pneumonia across different settings. And besides the pathophysiological factors that leads to pneumonia, in COPD, the use of inhaled corticosteroids have been shown to lead to increased risk of pneumonia, both in randomized clinical trials as well as observational studies. But contrary to studies indicating this increased risk of pneumonia among inhaled corticosteroid users, patients taking roflumilast didn't show any increased risk across studies investigating their role in COPD. So this can be a perceived advantage of using roflumilast in patients who are at a higher risk of developing pneumonia. Therefore, we are hoping to do further investigation to kind of clear out this or answer this question and estimate the risk of pneumonia in patients taking roflumilast. So given what's known so far about the effect and mostly or particularly safety of roflumilast, what's out there in terms of like previous studies that looked at the post-approval effectiveness and safety of roflumilast? And there hasn't been that many studies done so far. There were only a handful of them, very small-scale studies. And those studies reported that roflumilast-related side effects are actually more common and led to more frequent discontinuation compared to what was reported in the clinical trials. We all know that findings from the clinical trials on the safety and effectiveness of any medication is important. However, the safety of roflumilast when used outside of these clinical trial settings remains mostly unclear. Therefore, population-based studies are needed to answer these safety concerns and safety outcomes. So using this study, I'm trying to fill the gap in the literature by generating evidence on the use and comparative safety related to the use of roflumilast in the treatment of COPD in the real-world setting using a population-based approach. In order to answer these questions, I'll be using 4 aims, and before describing what each aim will look at, I'll first want to explain the relationship between clinical trials and evidence from the real-world setting. As you can see from the diagram, the body of evidence that is used for both the safety and effectiveness of a medication comes from either the pre-approval clinical trials as well as post-approval studies, or what we sometimes refer to them as the real-world study. Clinical trials provide information on the efficacy as well as safety of medications, but it is known that these studies are limited in terms of size, duration, as well as generalizability. And to overcome these limitations, real-world studies are important, and real-world studies will provide us effectiveness as well as safety information, especially long-term safety information that could not be identified from the clinical trials. And all the information that comes from these types of studies will help to develop the body of evidence, which will be used in the decision-making process. And the decision-making process can be reflected in terms of policy, treatment guidelines, as well as direct patient care. Coming to the specific aims, specific aim 1 will look at the medication use pattern of roflumilast therapy for patients with COPD and identify characteristics associated with its discontinuation. For this aim, we are hypothesizing that the demographic and clinical characteristics of patients will be different between groups in accordance with their persistence level. For the second aim, I will be looking at a safety outcome. To determine the risk of diarrhea in patients with COPD who are taking roflumilast compared to a triple combination therapy. The triple combination therapy consists of patients who are taking inhaled corticosteroids, long-acting antimuscarinic agents, and long-acting beta agonists simultaneously. And for this aim, we are hypothesizing that the use of roflumilast is associated with an increased risk of diarrhea compared to the active comparator group. For the third aim, I will be looking at the risk of the psychiatric-related adverse events, and I will be using the same comparator group, that's triple combination therapy. Similar to the previous aim, for this aim, we are hypothesizing that the use of roflumilast is associated with an increased risk of depression and anxiety in patients with COPD. For the final aim, I will be looking at the respiratory-related safety outcome, which is pneumonia, and its risk will be estimated among patients who are taking the medication of interest. Contrary to the previous two aims, for this aim, we are stating that the risk of the outcome is actually lower in patients taking roflumilast compared to the triple combination therapy. Going in details, the first study will look at the use of roflumilast in adult patients with COPD. Given the benefit and side effect profile of roflumilast, we think it's important to assess how the medication is utilized in the real-world setup, and specifically we will be looking at, again, the medication use pattern as well as characteristics associated with its discontinuation. The data source for this study is the proven market scan, commercial claims and encounters in the market scan Medicare supplemental data based from 2011 to 2015. From this data, we'll be obtaining information regarding enrollment, date of encounter, as well as outpatient, inpatient, and emergency room visits, medical procedures, and pharmacy records. This data is helpful in characterizing the real-world treatment pattern of millions of patients as they come in contact with the healthcare system. For the study population, a cohort of patients initiating the drug of interest, roflumilast, after its approval date will be identified using the following NDC codes, the national drug codes, and a new user cohort will be identified using the following definition, which is having no evidence of prescription claim for roflumilast during the baseline period. This baseline period is limited to 6 months prior to the start of treatment. The exclusion criteria for this study is age less than 40 years at index date, less than 6 months of continuous enrollment before and after the index date, and no prescription drug coverage. The index date will be the date of the first dispensing, and individuals will be followed starting this index date up to either treatment discontinuation, inpatient death, end of enrollment, or end of follow-up, whichever comes first. As it is evident from the stated objective or aim of the study, the primary outcome here is characterizing patients in terms of both clinical and demographic factors, measuring their average duration of use, as well as identifying their prior therapies before initiating roflumilast. These factors will be measured across the study period, as well as will be compared according to calendar years to see if there's any difference in their use over time. Persistence over a 6-month period based on a continuous claim with a gap of less than 90 days, and adherence with a prescription days covered PDC measure with an 80% threshold will be calculated. In addition to that, factors associated with discontinuation using both the bivariate and the multivariate variable analysis will be identified. For comorbidity measurement, I will be using the clinical classification software, and COPD disease severity levels will be estimated using proxy measures of disease severity. This includes the number of COPD medications, doctor's visit to for COPD, emergency department visits, number of pulmonologist claims, the number of months supply of rescue inhalers, and hospitalization for COPD. Further, the Dale-Charlson Comorbidity Index and the Frailty Index score will be calculated. As you may already know, the Dale-Charlson Comorbidity Index assigns a score to different chronic illnesses and uses the sum to predict adverse outcome in a patient, whereas the Frailty Index has the ability to measure risk factors for adverse health outcomes that are sometimes difficult to measure using traditional comorbidity score measurements as well as demographic characteristics. So we are thinking of these two things will complement each other in kind of characterizing the patient better. To identify factors associated with discontinuation, we'll be doing both the bivariate and multivariable analysis. For the bivariable analysis, the study cohort will be stratified into 2 groups based on persistence measurement, and patient characteristics will be compared between the groups. For the multivariable analysis, a logistic regression model will be constructed to look for factors that can lead to treatment discontinuation, and the model will include factors such as age, sex, comorbidity, and the proxy indicators of disease severity, in addition to other factors that showed an imbalance in the bivariate analysis. In terms of sensitivity analysis, persistence measurement will be varied to 3, 6, and 12 month periods, and definition of the gap for that persistence measurement will also be varied from 90 days to 30, 60, and 120 days. The PDC calculation will be defined as the number of days with roflumilast over a 90 days period, and that calculation will be repeated over a 180 days period. For the second study, I will be looking at the risk of diarrhea associated with roflumilast. Here, I will be conducting a comparative safety study to estimate the risk of diarrhea in patients taking roflumilast compared to those on triple combination therapy. In order to estimate the risk, I will be using an active comparator new user observational retrospective cohort study. The active comparator design in this study will estimate the risk of an intervention with another therapeutic alternative with the same indication as the study medication, or which is it will be compared against a medication that's given to patients at a disease severity level similar to the one to the study medication. So by using that triple combination therapy that I stated earlier, we are trying to find patients who are at a similar disease severity level as that of the study medication. In addition to that, the new user element dictates that the selection of treatment initiators and starting follow-up at the same time as the start of treatment. And this study design has been shown to decrease confounding and selection bias, and it's considered to be the current standard in pharmacoepidemiologic research. The data source that's going to be used for this study is similar to the one I described earlier in study 1. It's the proven market scan commercial claims and encounters, and the Medicare, the market scan Medicare supplemental database. For the study population, a new user cohort of roflumilast in the active comparator group will be identified in the patient selection period, and the new user definition is based on having no prescription claim for any of the study medications in the baseline period, which is 6 months before the start of treatment. And the index date will be treatment initiation date. Now, the use of the combination study medication is based on the coinciding claim for all 3 medications in the patient selection period. And the first day of the overlap of the claims is considered as the first day of use for that combination treatment. And that day will be used as the index date to start follow-up. Again, I will be applying a few exclusion criteria, which includes not having a continuous enrollment in the baseline time period, having a claim for asthma in the baseline time period, and having the outcome either on the same day or in the 14 days prior to the start of follow-up, which is the index date. The outcome of interest, diarrhea, will be identified from the inpatient setting, at least for the base case analysis. The inpatient diagnosis is selected as a proxy for identifying very severe cases of the outcome. And in order to do that, we will be using ICD-9 codes that will cover non-infectious diarrhea, functional diarrhea, as well as toxic or allergic diarrhea within 30 days after treatment initiation. The follow-up will start from the index date again, and it will go up to the occurrence of the outcome, a prescription for the comparator study medication or groups of medication, the 30-day follow-up period, disenrollment, or end of the study period, whichever comes first. For confounding control, which is important especially when we do observational studies, I'll be using a high-dimensional propensity score method. This method is a semi-automated method that tests a large number of covariates in claims database to find the covariates that have a high prevalence and greater potential for producing bias. And by using this large number of covariates, this method helps to reduce the level of residual confounding by either measured or unmeasured factors. In the high-dimensional propensity score estimating equation, we will have pre-specified factors. This includes sex, age, index year, proxy measures of disease severity, the Charlson comorbidity index, and the frailty index score will be forced into the model. Using a variable ratio matching technique, patients in the roflumilast group will be matched to up to 4 controls, and the overlap between the groups will be visually inspected. In addition to that, we will be calculating standardized differences both before and after matching process to see if the groups are more or less alike. And the threshold that will be used for the standardized difference is a 10% difference. In order to calculate the effect estimates, we'll be using a time-to-event analysis using both Kaplan-Meier plots with log rank test to compare the survival curves between the 2 groups, as well as the Cox proportional hazards model to estimate the hazard ratios. For subgroup analysis, we'll be categorizing patients based on age, less than 65 years, and above or equal to 65 years, comorbidity scores, as well as frailty index scores. And the effect estimates will be calculated for each group to see if there's any difference in accordance with the classification method we used here. For the sensitivity analysis, the follow-up time period after the index date will be changed to 15, 45, and 60 days. The outcome definition will be expanded to include outpatient diagnosis of the outcome. In addition to that, we'll be constructing a composite endpoint, which includes the outcome of interest diarrhea and treatment discontinuation. This is done because one of the primary reasons for treatment discontinuation described by patients was experiencing a GI-related side effect. So first, all treatment discontinuations will be recorded as part of the composite outcome. Later on, only a random sample of those discontinuers, based on a prevalence estimate from previous studies, will be identified and will be included in the composite endpoint to estimate the hazard ratios. In terms of bias analysis, the E-value will be calculated, which is also referred to as the evidence of causality in observational studies. The E-value is the minimum strength of association that an unmeasured confounder needs to have with both the exposure and the outcome in order to fully explain away the observed effect estimate. And this E-value will be calculated for both the calculated hazard ratio as well as the confidence interval closest to the null. And the higher the E-value means that the bigger the unmeasured confounder needs to be in order to fully explain the observed association. In terms of sample size estimation, based on a previously identified cohort, we have more than 9,000 initiators of roflumilast from the time periods within the study period, and we did a cohort study design with unequal sample size, with the ratio of exposed to unexposed set to 4:1 in order to estimate the sample size. And based on that, we will have the ability to detect an effect size that's even smaller than 1.2 in our study. The third study in this proposed work will look at the risk of anxiety and depression associated with the use of the study medication, which is roflumilast. And here the objective is again to estimate the risk of this adverse outcome in the real-world practice setting. The study design is the active comparator new user design I described earlier in study 2, using the data source similar to the other two studies, which is the Proven Market Scan commercial claims and encounters, and the Market Scan Medicare supplemental database. The study population that will be used for this study is similar in most ways to what was used for the previous study, but in addition, we will be excluding patients who had a claim for the diagnosis of anxiety and depression in the 6-month period prior to the start of treatment. And this was important in order to remove those patients who experience events that are related to a previous diagnosis of anxiety or depression rather than a new effect of the medication. In terms of outcome, we will be using a composite outcome that looks at both anxiety and depression. In order to identify anxiety, we will be using the following ICD-9 codes, which have been used separately or in combination in other studies prior to this. And the ICD-9 codes will cover anxiety, anxiety with depression, drug-induced anxiety, and generalized anxiety. For the depression diagnosis, it will be based on a previously used ICD-9 code with a positive predictive value of more than 90%. And this group of ICD-9 codes cover conditions that span from major depressive disorder to dystemic disorder, as well as depressive disorder not elsewhere classified. The follow-up time period will start at the index date, which is initiation of treatment for both the study medication as well as the combination study medications, and it will go up to either the outcome of interest, treatment discontinuation, prescription claim for comparator study medication or group of medications, hospitalization that lasts more than 30 days, disenrollment from the health plan, or end of follow-up. And for this study, we are limiting the treatment discontinuation period to 30 days in the base case analysis. For confounding control, we'll be using the same method described earlier, the high dimensional propensity score. And after the matching process, the group of patients will be compared on prior history of mental illnesses, which includes post-traumatic stress disorder, sleep disorder, as well as schizophrenia. For the statistical analysis to estimate the hazard ratio, we'll be using a time-to-event analysis, and a risk of the outcome will be compared across different groups based on age, comorbidity score, as well as frailty index. For the sensitivity analysis, we'll be doing adjustments on the follow-up period, as well as the treatment discontinuation definition. But in addition to that, we'll be also excluding patients with a prescription claim for selective serotonin reuptake inhibitor, antidepressants, anxiolytics, and antipsychotics in the baseline time period to account for past diagnosis of anxiety as well as depression. In addition to that, the E-value, which I described earlier, would be used to account for unmeasured confounding. We know that theoretically, high-dimensional propensity scores has the ability to kind of control for unmeasured confounding, but having the E-value is kind of an additional layer of confidence that gives us to kind of see if actually the medication and the safety outcome are related. A similar technique was used for sample size calculation, and again, we'll have the ability to estimate a risk or hazard risk, a risk ratio of less than 1.2, depending on our current sample estimation. My final study will look at the risk of pneumonia associated with roflumilast. Here, as I tried to state earlier, the addition of roflumilast to patients with severe and very severe COPD not only helps to reduce exacerbations and improve lung functions, but possibly also protect against developing pneumonia. And this advantage needs to be further investigated in a real-world practice setting. Therefore, in this study, we are aiming to evaluate the risk of pneumonia among roflumilast users compared to patients or triple combination therapy. The study design used for this one is, again, the active comparator new user observational study design using the same data source, that's the proven market scan database. For the study population, we'll be following similar techniques that were employed for the previous studies, but in addition to those inclusion and exclusion criteria, we'll be excluding patients with a diagnosis claim for pneumonia in the 3 months prior to the initiation of study medications for the base case analysis, and that time period will be expanded to 6 months in the sensitivity analysis section, which I'll cover later on. To assess the outcome, inpatient outpatient claim of pneumonia using the following ICD-9 codes will be employed. This claim-based diagnosis code for pneumonia has been used in previous studies, looking at US-based commercially insured COPD population, which is very similar to the type of study population we have for this study. The follow-up process will follow the same trend as the previous studies, and it will go up to, starting from the index date, it will go up to the earliest of the occurrence of the outcome, a prescription claim from the other group, treatment discontinuation, hospitalization lasting 30 days or more, disenrollment from the health plan, or end of follow-up. For confounding control, I will be using the high-dimensional propensity score, and the matched cohorts will also be compared with regard to the history of having acute bronchitis, cystic fibrosis, and tuberculosis. For statistical analysis, the same method will be used at the time to event analysis, and very similar type of subgroup analysis will be conducted. When we come to the sensitivity analysis, one thing that's unique to this study is because of the previously known association between the use of inhaled corticosteroids and pneumonia, we will be grouping the comparator group into two based on the timing of addition of the inhaled corticosteroids. So we will have patients who added ICS at last to their triple combination versus others who added ICS in an earlier point in time. And we'll be re-estimating the hazard ratio to see if the risk of pneumonia is similar between those two groups. For the sample size estimation, since we are looking at a benefit rather than harm, the risk ratio will have kind of a reverse direction, which will be less than 1. And based on our sample size estimation, we will have the ability to detect an effect size that's even lower than 0.8. Finally, I will state some of the limitations associated with the proposed study, which starts from the exposure definition. We are using prescription claims, which does not reflect actual ingestion of the medication. There could be misclassification in outcome assessment, since diagnosis is based on ICD-9 codes, which are susceptible to errors and inaccuracies. The data lacks information on important confounders like smoking, and study finding will only be generalized to commercially insured US population. These are some of the limitations of the study. And thank you. And please recycle. Please recycle. So the question is, for the diarrhea analysis, will I be excluding patients who had conditions that are usually associated with having diarrhea? So I will be measuring those conditions separately and compare them after the matching process to see if the two groups are balanced in terms of those. If they are found to be unequal between the groups, and they will be included in the multivariable Cox proportional hazards model in order to adjust for them, because they are risk factors for the outcome. Dementia. Yeah, it's really difficult to identify those outcomes, especially in claims data. So like one method I'm thinking of using is like, if they have a diagnosis for dementia, I'll be accounting for that. But otherwise, I'm trying to overcome that through like sensitivity analysis by changing the follow-up time period and like outcome definition, something like that. Thank you, everyone. Thank you for coming.